Hello and welcome to Rio Calling, taking over the feed from HIV the morning after for a few days. This is Dan Hall. I'm here in Rio, reporting from AIDS 2026, the biggest HIV conference in the world. Gathered here are the greatest and the good from the global political, activist, community and medical members of those involved with HIV. Joining me is author and ACT UP activist Dan Glass. And together, we're going to get the thoughts from the convention floor on topics that are most raised by the guests of HIV the morning after. Unfortunately, our flights alone have cost us around £2,000 each to get here, and so any help with our expenses would be much appreciated. The link to our crowdfunder is in the show notes. And thanks also to BHIVA, the British HIV Association, for helping to cover our costs, and to HIV iBase for their further assistance. This episode is about medical progress versus lived reality. And before meeting with Dan down in the hotel lobby, let's hear from a couple of the podcast guests. Anthony Bird was diagnosed in 1995 at 28 after an illness that nearly killed him. Effective treatment arrived the following year.
I mean, it has very little effect on my life now. I take my meds once a day. The side effects for the meds, they kind of stopped about 15 years ago for me. So I don't, so I take my meds once a day. I go and see my consultant twice a year. And that's pretty much it.
Jim Vogiatzis was diagnosed in 1988 and survived the pre-treatment years. Combination therapy saved his life.
Even with the advent of combination therapy and the fact that it has, halted HIV in its tracks, where it's given some people an undetectable viral load, which means they can't pass the virus on to anybody else. Some of the side effects, will last you for your whole life. So, for example, for myself, I've been left with peripheral neuropathy, which I will live with for the rest of my life. One of the newer drugs, has caused the reduction of my bone density, which means I now have osteoporosis and osteoarthritis. So if I fall over, chances are I will break my arm or my leg or wherever much easier than a healthier person.
Links to their full episodes are in the show notes. Now then, I'm off to see co-presenter Dan Glass.
Morning, Dan. How are you?
Good morning, Dan. I'm well, thank you. How are you?
I'm good.
I did have a bit of an adventure yesterday.
I know. You had your Titanic moment.
I had my Titanic moment. I was out on a boat and we got stuck out there for over 2 hours and we thought it was going to sink. I know.
Jewish mum over here was having a meltdown.
So you nearly had to finish the last 3 episodes on your own.
I know. I would lose my rose.
Oh my God. I was out
on the piano. Which scene in Titanic were you doing? Were you in the piano or in the sea?
Well, I tell you what, I certainly wasn't in the car.
You weren't in the car, okay.
I wasn't in the sweaty car.
Were you gripping onto the bed? Oh, honey. Did you get some sleep or were you just nervous all night?
Nervous all night. Oh. But it's all good. It's all good. I can't wait to get back to the conference floor.
I was thinking this would be rubbish if we lost you, Sophie and Mpact, 3 of the most amazing HIV advocates that we have in the struggle. That would, as if there's not enough drama at the conference.
I know.
And then that.
And just to remind people listening, so I was there with Sophie and Mpact, who have been guests on these specials. You've probably heard them. And they kind of said to me, look, let's go out and do something beautiful. Stop doing the podcast for a few hours, just like Dan instructed me to on yesterday's episode. Yes. And then we nearly found ourselves at the bottom of the sea.
There was a storm yesterday. I was thinking of you. I was still at the conference and it started doing it. And I was thinking, are they going to be all right? But we've got you back.
It was great down at conference yesterday, and just as we were leaving, just after we recorded our closing, I ran to this wonderful sex workers protest, protesting for sex worker rights, sex worker sexual health. It was just brilliant, and it was noisy and joyful. back for today, and today's episode is what?
Today's episode, I've been thinking a lot about this. What am I going to do when it's over?
Which is carry on doing this with our real life.
Yeah, exactly.
Dan, when are you going to go to Costco today?
Yeah, exactly. Yeah, but I mean, yeah. So I've been thinking a lot about this. Medical progress versus lived reality. That's what we're going to focus on. I've been thinking a lot about Dr. Beatrice Grinstein, who serves as the International AIDS Society President and AIDS 2026 Co-Chair, who cuts straight through things. She's like, we've got to talk about criminalisation. All the countries which criminalise homosexuality, which criminalise drug users, which criminalise sex workers, how can we be talking about medical progress if some people can't even be who they are? So that for me is a real clear example. Cut through it like a knife. Let's look at the differences between medical progress and what that actually means.
Because just because the medicine is there and it's good, doesn't mean that that's accessible to everyone, does it? There's no point in a medicine that's sitting on a shelf.
Exactly. I mean, this is one of the primary mantras in the movement. It is more than pills into bodies. If you can't even be yourself when you're going to the doctor, when you're going to the hospital, and talk about your own lived reality as a migrant, as a woman, as a drug user, as a sex worker, etc., then you're not going to get the holistic help that you need, let alone the actual medical support that you need. So the moment people are criminalised for who they are, that means there's no point in talking about too much medical progress, because there's such a disconnect with how they're going to get the support they need. I've experienced it myself, as we both are. We were kids of Section 28, which banned the promotion of homosexuality in public institutions between the years of 1988 and 2003. As a young gay queer kid, could I have gone to get the support that I needed? No, because there was a ban on talking about being homosexual. And I see there's a direct correlation between being a child of criminalisation of Section 28 and getting HIV, because there was no adequate sexual health education.
No, there was none whatsoever. I entered sexual maturity with no information whatsoever.
Yeah, no, nothing. So that's an example of criminalisation and how that leads to, devastation, and how what we're talking about today, the disconnect, the different realities between medical progress and lived reality. Don't get me wrong, I was saying to my lover last night, it is astounding being here. It's so inspirational. And from the doctor's side of things, who are pioneering so much medical progress that we couldn't have dreamt of a decade or two ago, it's brilliant, but it has to be applied in our lived realities on the ground.
It is coming up to the time for our coach.
Well, I'm going for a swim.
Oh,
I'm going for a swim.
Of course you're not coming.
I'm coming on the coach and yeah.
Should we go and see Dr. Tristan Barber a bit later than planned?
We can't not.
I can't
live. What was that song? I can't live without you.
I can't live if living is...
There we go. Can't live without our Tristan. So of course we have to. I think we'll be recording all day today, and then we're going to go to the Global Village, and actually that's quite important. That at the International AIDS Conference is a huge room with 100, 150 stalls of people who are expressing their lived reality of living with HIV from movements across the world, and we're going to go interview a few of them, and I'm really excited.
Absolutely. And also, for those of you who listen to other podcasts, I've got an exciting bit of news that Dan doesn't know yet. I've been asked to deliver a dispatch from the conference floor for the HIV podcast, and they're doing an IS special tomorrow. They're dropping one, so big shout out to them.
Wow.
And really looking forward to doing that.
The ripple effects are huge. Well done.
Yeah, and I'm genuinely proud to work for them. I think us podcasts dealing with HIV and stigma we're not in competition with each other. We're all different, and we're all hopefully raising the bar, raising the knowledge, and challenging the bullshit.
And I've got something that Dan doesn't know yet. I've been, now not so secretly, planning my questions for when I interview Dan and his mum, because Dan's mum and her experience of her friends living with HIV who unfortunately died of AIDS was such a catalyst for Dan being such an incredible human and activist and ally. So yeah, Dan, I'm going to interview you and your mum on a special episode of HIV The Morning After.
Wonderful, and we'll make sure we have some wine for that. Right. See you guys later when we go to chat with Dr. Tristan Barber from
BHIVA, British HIV Association.
Thanks, everyone.
Welcome back, Dr. Tristan Barber, Chair of BHIVA, British HIV Association. We are now going to be looking at the differences between the medical reality and the lived reality on the ground, which often don't meet in the middle. Can we go and explore that, please?
Tremendously important point. So we see fantastic advances in the medical treatment and the medical prevention of HIV. But of course, what we don't see is those developments being available equitably. This is to do with resourcing, it's to do with different structures in different countries and different priorities for different governments in terms of rollout and funding. Even in the UK, we see very differential access to new technologies around the country. People perhaps in bigger clinics where people have undertaken research studies may offer newer treatments earlier. And we need to make sure that everyone is supported to have equitable access to new treatments in the right place at the right time and for the right person.
I'm Antonio Flores. I'm a senior HIV/TB advisor with MSF, Doctors Without Borders. So magically, we've come a long way. We have treatment, we have tools that are easier and easier to use. So now we have treatment that can be taken once a day. We've got prevention that can be given a few times a year, even 2 times a year only with lenacapavir. But in terms of lived realities, people need to access these services. People need to have access to these tools.
So I'm Damien Fagan, I'm with Gilead Sciences, part of the medical team, and we need to find ways in which we can bring medication to people rather than relying on them having to find ways to come to it.
Now that we've got medication, everything's fine, right?
Hello, I'm Zipa from ICWAP.
Fine.
Yeah, medication been really good for health, but medication is not enough because there are so many associated programs need to be added into the HIV response. So pills is not enough.
Hi, it's Sarah Fagan from ICW Asia Pacific, and we can't think pills are enough. Not everybody has access to pills, so we're not there yet. We can't say that pills are enough, not if everyone doesn't have the pills.
Hello, I'm Christabel. I'm from Australia. I live in close to Victoria and Thorne Harbour Health. A lot of these pills are still tested on men's bodies and men's hormones and how men will react to it. And I know a lot of us still experience side effects that we don't get support with. We're told it sort of falls into that, you know, women's problems. It's probably something else. So we've only just scratched the surface with having pills.
What she said. Yeah.
Yeah. This is so good.
My name is Derrick Mapp, and I'm from San Francisco, California. And what brings me here, my community. One of the things that HIV really came to the forefront with in our thinking is our healthcare system doesn't care about the inequalities that are engaged with it. And so the problem with taking your medication, just concentrating your medication, did not take away from your concerns around stable housing or stable employment. What HIV has torn the bandage off of is this idea that somehow all the research and discoveries that were made was being available to everyone.
I'm Laura Waters. I'm a sexual health and HIV physician. I work for Gilead and the Royal Free Hospital. There are far too many barriers. Some people don't even know they need treatment because they're untested. Those who do enter services may not be supported to continuing care and end up not being seen at all. And people who are on medication may not be having the discussions to help support them to stay on it.
I'm Luca Stevenson. I'm a sex worker and sex worker advocate. I think often sex workers can be quite critical of the HIV movement because it has been quite focused on, in some communities, to like men who have sex with men. For example, access to PrEP is extremely important for sex workers, but we were not involved in the first conversation about access to PrEP, because we're not seen as more at risk than men who have sex with men. And I think in the HIV movement, we also have to break the barriers and recognize that all the key population have the same priorities.
I'm Joan Stevenson. I'm a community facilitator. I am also a person living with HIV now for 25 years. Some people still not getting meds. They don't have access because they're afraid of going in to the health center. So yes, meds is there, but how many persons are really receiving that, right? So that is a big thing. What about the persons who live in a volatile area where they can't come out to go and get meds? That's another issue. How do we get it to them?
Hello, my name is Axel Bautista, and I'm the director of programs at Mpact Global Action. We advocate for sexual health and sexual rights for gay, bisexual, and queer men around the world, living with HIV and without HIV. Of course, there's been advancements and improvements in medication, in biotechnologies focused on HIV. However, we still have a huge gap on access. Rich countries like the US or even in Europe, they do have these new technologies. Not everybody have access to them. And if we focus globally, the situation is even worse.
All right, so my name is Derrick Powell, and I'm a retention navigator, and I work with the Jamaica Network of Seropositive. It's the only organization that advocate for the rights and concerns of people living with HIV. If we, as a nation, as a society, as a world, it would start, if it only could start from the head. So the heads of government, the heads of states, the presidents come right down.
My name is Brenda Crabtree. I come from Mexico. I'm an infectious disease specialist and an HIV researcher for the past almost 2 decades. All the support to the causes of people who are more vulnerable for any reason, those initiatives are now in danger.
Coming away from the conference floor for a moment, it's Dan Hall here, producer and host of HIV The Morning After. Remember, you can support our costs for Rio Calling by going to the crowdfunder. The link is in the show notes. And do subscribe, rate and review these specials and the main podcast. You can do this in your podcast app, and if you like what you hear, please do tell your friends and colleagues. Now then, let's hear from a couple more of the podcast guests on today's theme, and then it's straight back to the conference floor. Mark S. King is an American writer and activist, diagnosed in 1985. For a decade, he prepared to die.
I had a life ahead of me and I was prepared to live. And then they said, you're going to die. And then you work for years to come to terms with that, to emotionally prepare for that. And then they say, oh, wait, nope, sorry. Turns out you're going to live. And you go, what? Oh, I am? You mean, and then as so many people living with HIV during that period responded, you mean I quit my job and went on disability and ran up the credit cards and took a trip around the world and told my boss to go to hell, and now I'm going to live? Shit. Because I had emotionally prepared myself to die, and now I'm not, and I'm broke and haven't worked in 10 years, and what do I do now? And I know how ungrateful that sounds, and then you feel guilty for not feeling grateful. It is a mind fuck.
Chris Smith was Britain's first openly gay MP, and later the first parliamentarian to make his HIV status public. He has lived with the virus for nearly 40 years.
The advent of combination therapy has transformed the nature of the uncertainty, but what none of us know is what someone who has lived for 38 years with HIV is going to face over the next 10, 15 years.
Zurich Mapp, Anthony Fauci said something interesting over a decade ago to a bunch of public health students, and that was, we have everything we need to stop HIV in its tracks. We could eliminate HIV. We have every tool that we need right now. We don't need new medications, literally. We have every tool. We don't have the social will. When will we get the social and political will to make it happen?
I'm Joan Stevenson. As we said, rethink. So think out of the box. What would you do and how would you do it? And put it in perspective.
So, hello, I'm Luca Stevenson. One of the criticisms of sex workers towards the HIV movement, and of course we are a huge part of the HIV movement, but it still sees sex work as a vector of disease. The reality is like sex workers' health is much bigger than HIV. Yes, of course HIV is an issue, but so is cervical cancer for sex workers who need like testing, etc. So is access to abortion for female sex workers. But however, these issues are much less important than HIV because whether we want it or not, we are still seen as vectors of contagion. And the reason why sex workers are included in the HIV response is not just because we want to protect sex workers, but we want to protect society as large, clients and the family of clients.
My name is Maxx Boykin. I am the manager of the Save HIV funding campaign and also the movement director for Black South Rising. And what we are trying to do is make sure that we're able to save as much HIV funding, not just in the US, but also understanding how in which that impacts globally. And for myself, this is my first time at any of the international conferences. I've done a lot of domestic work around HIV, but this is actually an opportunity to do the deeper connection with our global advocates. We do not have the political will. And this is not just in the United States, we're seeing it across the world, and we're spaces where they might say that they want to do this, they want to address this, but they are not putting their money where their mouth is.
My name is Eliane Becks, Nininahazwe, HIV stigma fighter. People here in Europe, they have good food, they have access to everything. But if you look to people from middle income, then they have also their different needs. We are forgetting like access to clean water, access to alimentation, food. Those are also health. Some people, they are not gonna take their pills because they have empty stomach. Then they start stopping. I didn't eat today, then I will not do it. I will not take it. I know some of the people in the villages, when I go in the villages in Africa, in Burundi, I talk to them. So sometimes we don't take because we didn't eat.
I'm Antonio Flores. I'm a senior HIV/TB advisor. If we say today, we're here at this conference saying that there is this tool that can be given only twice a year, yeah? So for people to have access to it, you have to involve the people affected, yeah? Because otherwise, the people who are not affected, they may have other priorities, they may not see the priorities. So involving the communities, giving them a say, involving them in the governance, in the budget development, in the program design is really key.
All right, so my name is Derrick Powell. Once we have the funding and we can start go out in the field, it would be a very, very, very big improvement for us because we can reach people where they're at. For example, some of the things that we do in Jamaica, we do field visits. So if we see somebody not coming for their appointment, we'll go and look for those persons.
My name is Brenda Crabtree. Doing a podcast is a way of solution. Awareness is key. Engaging with communities so people spread the word. So being informed, and obviously science. We have to use science for the benefit of the person. So it's important to have the data so we can prove stakeholders, decision makers that what it is important.
My name is Fatima Hassan. I'm from the Health Justice Initiative. So I think what's clear in the last year, based on the Trump funding cuts and the administration's sort of irrational decimation of HIV/AIDS services and programs, particularly in South Africa and elsewhere in the Global South, is that we need Global South governments to have the political will to deal with the systemic barriers and issues. So I think asking for drug companies to act fairly, to act ethically, to be benevolent, that's not a sustainable solution. We've seen that with whether it's GlaxoSmithKline or Boehringer Ingelheim or Gilead or Pfizer or Johnson & Johnson, or we just saw that in the last few days with Merck. Their bottom line is profit and their bottom line is not equity, and I really don't think that they give a damn about people living in Africa or whether we can benefit from innovation at the same time and in the same manner that people in the global north do. We saw that quite clearly in COVID. We were second-class citizens, we were at the back of the queue. And so what you need is global south governments to get out of the World Trade Organization's TRIPS agreement in relation to pharmaceutical products. I think it's a scandal and a crime that given all the public health crises that we're facing, we still have intellectual property rules that allow a life-saving medicine to be granted a patent. And in many cases, these drug companies are extending the patent with a practice that's known as evergreening. So they file for secondary patents and continue holding on to their monopoly. So if you want to address the abuse of power by the pharmaceutical industry, then you need solutions that deal with the systemic barriers. One is the intellectual property rules. Second is trying to claw back against the power of the pharmaceutical industry. I mean, just a few days ago, we found out here in Brazil at the International AIDS Conference, ironically, that a company called Merck that is at the moment clinically testing a potential HIV prevention technology announced a deal where they tried to get a lot of great publicity out of, but the deal for licensing, for access for that excludes Latin America, excludes countries like Brazil, the very place where the conference is being held.
Welcoming back Dr. Tristan, Chair of BHIVA, which is the British HIV Association. What are some of the solutions to make the landscape of the medical reality and the social reality more harmonious?
I think that's an excellent question, and I think what we really have to do is take our new medical technologies, but then individualize the person that's in front of us and understand their lived reality and find out where the best intersection of those are. So really thinking about, for an individual, what are the factors that mean that they might need a new treatment? What are the factors that mean they get offered a new treatment or don't get offered a new treatment? And then for me, there's also something important if we're thinking about someone living with HIV. We need to think about also their HIV age, not just their birthday age, if you like. And the reason I think this is important is that for people who were diagnosed before we had successful triple therapy, these are people whose entire life course has been affected by HIV. They may have been told they had a limited life expectancy. They may have been given very early toxic treatments. They may still have legacy side effects from some of those early treatments. Whereas someone who was diagnosed more recently will have been told they can have a normal life expectancy, and if they're undetectable on treatment, they're not going to transmit their virus sexually. And so you can see already, even if you're just thinking about your HIV age, you've got a very different lived experience of HIV, and that may affect what kind of medical treatment you're accepting of, what kind of research studies you're happy to participate in. And so all of those factors mean that we need to individualize the person in front of us when we're thinking about what the best prevention approach is or what the best antiretroviral therapy innovation might be for them.
So hi there, Dan. It's great to catch up with you again. We're now at 1:30, which kind of means it's time for us to stop interviewing people and have a quick round-up chat, and then I'll get off and edit this episode. What have you got out of the people you've been chatting to this morning and the conversations you've been having?
Oh, well, I bumped into someone who I saw at the last International AIDS Conference that I was at in 2016. So sweet, and we did HIV Blind Date, the show together last time here, and that's one thing I've got out of it. Friendships. We're not just here to fight, which we are, to have a political analysis, but the friendships that are born from here. She was like, it's so nice to see what you've been doing. She told me what she's been doing. By the way, off the cuff, all this sex chat is making me miss my gorgeous lover. Oh my God. Not just for the sex. But...
Do you want to put a little message to him for the edit?
Oh, Dan, I'm never speechless. Zeno knows I adore him. Adore him. And I'm just very smitten.
I'd say for those who can't see Dan right now, he's kind of blushing, and he's got this very unactivist, smiley grin on. Like all the fury has left his body temporarily.
I know. I'm very smitten kitten at the moment, Dan, which is really lovely, but also difficult when there's also a lot of other hotties here. I'm just thinking about him. And then I had a chat with Mark King, and Mark King, amazing activist, was like, it's so brilliant how the younger generation, they've got all these multiple boyfriends and they're polyamorous and all of this. I'm like, I feel like I'm stuck in the 1950s. But that's all right, you've got to go with what makes you tick, right?
But also, everyone needs their conference husband. But I'm slightly uncomfortable by how happy you are. Oh, so I just want to make you, I just want to get a bit of fury back into you.
Okay, good.
We've just seen another Gilead protest go by. I don't know if it's my imagination. This is my first AIDS conference. It seems to me that there is a lot of protesting and not a lot of rethinking, rebuilding, rising. And I keep coming back to this hashtag, that it's feeling more and more like an attempt to put a sheen on something that simply doesn't exist. Because we're seeing like 4 or 5 protests a day, aren't there? There's constantly something happening, and that one that just went by.
And the one yesterday, the sex workers and HIV Alliance, that was incredible.
Yeah, and we just saw Hamish Noah, alumni of the podcast, in the Gilead march we just had there.
Yeah.
That was quite a big march, actually. Yeah. There was a lot of people in it, and it was collecting people on the way.
Yeah.
So people are angry.
People are angry. And the thing is, it's not like it was 2-3 decades ago when it was like panic because there wasn't the solutions. This is why it's even more infuriating. We have all the tools in our arsenal to end this crisis. We have them. We know what we need to do medically, socially, legally. We know what we need to do. But it's the greed which is maintaining the status quo.
So you see, you are the 4th person that said that to me today. So that is clearly a feeling that's in the air, that all the tools are there.
And when the international aid say, they're making statements like, we welcome protest, which is, when you unpack that, it's like, you could say it's like co-option. It's like, we welcome protest. Yeah, but as we see the protest, but what are you going to do about it? Like, it can be a very middle class, very comfortable perspective to say, oh, we've done, we've welcomed protest, we've allowed people to express themselves. But you're so comfortable in your domination, you're not actually going to do anything about it.
So do you think welcoming protests is, in a way to control them? Because by welcoming them, you therefore know in advance what they're doing. You can make sure that you put nice paths for people to walk down, windows of opportunity for them to do their thing.
It's a democratic situation when there's no democracy when it comes to pharmaceutical greed.
So how would you say...
It's the rules of a democratic organisation.
So we've just seen a protest go by here. How would you say that is different from the storming that you witnessed on the very first day, the pre-conference day that we were here? How are those two things different?
If we look at the protest yesterday, the sex workers HIV Alliance was full of music, full of joy, full of celebration, full of fire and fury. I found that really inspiring. The ones that we're seeing on the regs about pharmaceutical greed, people holding the placards, I brought up the issue with you the other day about the NGOisation of resistance.
And can you just unpack that a little bit for people listening?
The NGOisation of resistance. And I will never do anywhere near as well as Arundhati Roy, the writer who came up with the concept. I think she came up with it. Anyway, she wrote about it. The NGOisation of resistance is, so you have, in the ecosystem, you've got the pharmaceutical corporations who are almost like the nemesis for all of us, right? Then you've got the state actors, people who are coming from government. Then you have what's called in, I think Hindi, SACA, the buffer zone, the NGOs, who are in this middle ground between the government and the grassroots. They often depoliticize the grassroots because they're in conversation, they're doing a negotiation with the government, right? But they also need to sustain themselves, so there's a lot of money that goes around. There's cases like Oxfam. The heads of Oxfam are on however much money, ludicrous amounts of money, because they need to sustain themselves and they also want to earn a lot of money. at the expense of the people they're supposed to be supporting on the ground. So it's a pacifying culture for actually grassroots resistance. Now that's why I really enjoyed the one yesterday, the Sex Workers and HIV Alliance, because they're genuinely grassroots people power movement. Then you get a lot of the more kind of, I guess middle class, comfortable dominating NGOs, which kind of pacify the grassroots and have the kind of in-bed effect with the government. Does that make sense?
Yeah, no, totally. And I suppose they would argue they have a taming effect so that what ultimately those grassroots want gets delivered. They would argue, wouldn't they, that grassroots activism never changes government mind. What you need is that to be cleansed, put through the wash, put in a suit, and then delivered in a way that a government will hear and act on.
They can say that, but that's just one part of the puzzle. You know, there's been so many instances where NGOs have parachuted into communities, spoken on behalf of people, and not let people transform their own situation. This is we've heard countless amount of times, nothing about us without us is for us. And this is why I'm part of ACT UP, because it's people living with HIV, we're speaking for ourselves, with our allies. But in NGOization culture, you get a lot of people who aren't affected by the problem, speaking on behalf of people like myself who are affected by the problem. And that relates to the other kind of mantra of effective social change, that transformation must start with yourself. The people affected by the problem must lead the struggle with our allies. So this is where NGOs can become problematic.
And so speaking of that, it now seems ironic that two men are going to be presenting an episode tomorrow that is about women and HIV. But having said that, I do assure people listening that whilst Dan and I will be presenting it, we're going to make sure that men's voices don't dominate that episode. But Dan, before we finish for the day and I go off to the edit and make myself 5 cups of coffee, what are your immediate thoughts about tomorrow's episode? What are you hoping to get out of it yourself? What are you hoping to learn?
Bigging up to people like Sylvia Petretti, a friend, an incredible visionary and activist who heads up Positively UK. I'm very lucky. I've learned most from women when it comes to the struggle and what we need to do, not just on an intersectional level, but on a strategic level, on a intergenerational eldership level, self-care level, so much. So for me, it's just I want to learn more to strengthen my commitment to feminists, HIV and AIDS revolutionary movements in the ways that I'm needed. But also, there's still gay men, queer men out there who think it's all right because they've got medication and they can have sex in the way they want. And I'm really happy they've got medication and can have sex in the way they want. But the struggle is not over if we look at the fact that more women in the world live with HIV and AIDS, more women have much more multiple levels of barriers to access to healthcare than men do. Really, feminism and women's liberation is at the heart of the struggle.
And I've got to say, Dan, don't get me started on the Clapham I'm all right Jack gaze.
Yeah.
We'll be here all night. Many thanks for listening to Rio Calling, temporarily taking over the feed from HIV The Morning After. My thanks go to co-host Dan Glass and to BHIVA's Dr. Tristan Barber. Paul Lee Nidu at UnstoppableMonsters.com composed the theme tune. And of course, additional thanks go to BHIVA, the British HIV Association, to HIV iBase and Murray Lang. Remember, challenge HIV stigma wherever you find it. This is Rio Calling, and I've been Dan Hall. See you tomorrow.